for having us here for this wonderful topic, the university initiatives for millennial healthcare professionals. I think this is very interesting. I mean, it made me put my thinking hat on and I started thinking, okay, what does it mean? And Raghavan and sir has already said few things, but I'm looking at and sir has already said few things. But I'm looking at, we're training the students, we're training them to treat patients, and I think we're training the students, we're training them to treat patients, and I think they'll have experiences and all these things. But the situation is so rapidly evolving. We don't know what's happening tomorrow. Today's learners, they'll be in the profession for maybe next 35, 40 years or maybe even more. So how do we make them or keep them maybe even more? So how do we make them or keep them ready? So some of the things which at least we can see that okay, what's likely of the things which at least we can see that okay, what's likely to happen in maybe next 5, 10 years. We don't know what's going to happen in maybe next 30 years, maybe next 5, 10 years. We don't know what's going to happen in maybe next 30 years or so. But few of the things which are already on the horizon are precision medicine. But few of the things which are already on the horizon are precision medicine, genomics. I think, and then all these AI-linked things, everyone is wearing a smart watch and all real-time data is being captured, chips and all augmenting the capabilities. Now it is done for the patients, but maybe tomorrow it will be done.
Half my faculty is here all around, and they've really, I represent, what they've been working on. We had about 1,200 students replied. 70% preferred a hybrid asynchronous learning, and 40% rate the quality of the classes that are being conducted as of date as average or poor. So I think with that background, we need to implement changes to bring about the millennium, how to engage them. And the way we continue to take feedback from students, we have two initiatives. One is a Kuluguru Katta, in which I think for those who understand, a Katta is a place where you chit-chat. So as a Vice Chancellor and all my team, we go and say, University Apल्या Dari. That's a Marathi saying that university is reaching. And we go region-wise and take inputs from students. And the second thing that we have started is the Maharashtra Association of Resident Doctors. We have a system called a town hall. So we keep taking feedback from them and implement. So what I'm talking going to be a result of that. And when we wanted to do the change, we did a SWOT analysis of the existing, strengths of the university with over 600 colleges and how many students. I think the sky was the limit. So that was a huge strength, and the potential of the National Education Policy 2020 and two other things, the National Health Authority's National Health Mission, that policy document which came out, as well as the National Digital Health Mission. And I thought that is going to be the disruptive. How are we training our students for that? Now, how to bring about these changes? I'll just mention a few more due to paucity of time, but something that will interest everyone. One of the things is like the electives. How did we use it at the university? We called it the SIP program. SIP, we all know, is a structured investment plan. And we at the university faculty, and we said, well, this is our structured investment plan for the future. And that is how we started this, where interdisciplinary students apply, and we match the goals, their learning goals, as what the institution can offer. And they are going in not just interpathy, but they're going interdiscipline. They're going to IITs, they're going to Center for DNA Fingerprinting Diagnostic, they're going to the National Center for Cell Sciences, NIV, NARI. I mean, you name it, they're going to the labs if their research is their interest. They're going to each other. They're going to allopathy. People are coming to learn Panchakarma. It's amazing when you leave it to the students how they integrate with them. So in that, they are learning to understand each other's, and I think that will lead to the teams working together for patient safety. So I think this is a very, very important program which is running. And this year we sent about 800 to 82 institutions. And we map them and mentor them with logbooks and things. It's not just a go and do what you want. So everything is very, very specified. Another interesting thing is, I have Varsha here and Payal here. We've started a Degree Plus program. Degree Plus program is an online on an LMS, which we have 10 modules, and the 12th one, which is the most important, is the Digital Health Foundation course. And this is 13 modules, which is credit-based, gives you 2 credits with a certificate download, assessment, and what is interesting, it has a virtual lab to experiment with. Because the future students and teachers are going to need this. So this we've done it, and that has been, I'm very happy to say, launched by the Honorable Health Minister as this thing. It will be put on iGot and available free to every doctor. We've developed it with the help of IIT Mumbai. And Rizwan Koita, who's helping me in this, let me tell you, he is today he's not a doctor, but he's heading the NABH. He's the president of the NABH. And just last month, we've interacted with him and released national digital health standards for accreditation, which is going to bring in the patient safety. So this is where we are doing an academia interaction with industry, with partner. This PPP model, which the NEP looks out at, NUHS is very happy to be implementing it across the colleges. So this was something about the UGs. Mental health is going to ensure a huge problem. We look at it. So we've started helpline. Incidentally, it's called Madhuri. And we've also started, I will elaborate it later. And we also are doing, have a psychologist helpline. We've launched an app called Manas, and the Ministry of Health is looking at, no, this is not the telemanas for treatment. This is for preventive and robust health. So it gives time management, good sleep hygiene, social connectedness, digital technology, that kind of addiction. So the name will be called Madhuri also. Thank you so much. So then assessment drives learning. We've blueprinted entire these things with all half the faculty has been part of it. So it's blueprinted for medicine, for surgery, your allopathy, Ayurveda, the physiotherapy, nursing and dental. So this is something. You have like enumerated a whole string of
initiatives. Where would they start from?
I think it would be excellent, and I would say 2 priorities which I didn't get to enumerate. I think we should concentrate on the teachers, and for that we have just got the curriculum ready. We are developing a faculty development academy, which is beyond just medical education, but we've identified 4 verticals, Payal. So we've identified education technology, research, IT, and administration, including financial, legal. These are competencies which will make our teachers stand at par with top administrators. And we are going to do this like you mentioned, universities don't have, but NUHS is very happy. We've got the government sanction to run it as an autonomous Section 8 company. It's going to be called Chakra. Chakra because it's a hub and spoke model. Chakra is in our Indian flag. Chakra is Ayurveda, so we have integrated, which is going to, yes, and that in Chakra, it's the acronym for Consortia of Health, Applied Knowledge, Research with Autonomy. This is a Section 8 company, which is the Asian Development Bank, has given us the sanction. We're getting 80 crores for setting up, which is going to have a state-of-the-art simulation lab in a hub and spoke. As he mentioned, 4 crores for that. We're going to have a museum on wellness. No health universities, because this is how we can communicate to the public perception of healthcare providers.
I think, Madam, your priority itself is an entire project by itself. It's an entire project by itself. Thank you so much for sharing that. I think we're all looking at the changes that are going to happen today in Maharashtra, but tomorrow all over the country, where we are going to have to move out of our comfort areas of academia and explore parallels that are affecting healthcare delivery, because patient safety, I think, depends on all of that put together. And it was Darwin who said that it's not the strongest person who's going to survive, and neither is it going to be the person who's the most intelligent. It's going to be the person who's most responsive to change. So I think we all need to start becoming more responsive. And one area,
just because of the change that you brought in, if I can jump in, I'm very happy to announce that we are also 2 enterprises have started. One is Disha and the other is Drishti. Disha is a direction which is our incubator for health. Okay. And Drishti is a interdisciplinary research, which is already doing 3 large into allopathy and Ayurveda, and the guidelines are
Madam,
ready
I'm
for the
scared
country.
you're going to cover all my questions with your answers. But no, fortunately, there's one area which we have not yet touched upon, and which fortunately I think Dr. Avasthi has an area of interest, and that is economics in health education. I think somewhere we do not give enough importance to healthcare economics in our educational system. So Dr. Avasthi, I think I'll request on you to elaborate on that. This is your area.
Thank you very much to the organizers and to all the panelists here. And I have the advantage or disadvantage of being the last in the panel to go, especially with all the initiatives being taken up by MU. But let me say that millennium for everyone is different. What millennium? Your millennium can be different from mine, and hers can be different from his. So perhaps we're not talking of a millennium, we're talking of millenniums from each and everyone's perspective, and from the best perspective. You said economics has not been touched. Well, it hasn't been touched by us, perhaps by us sitting here, by the medical universities. But economics, health finances are big specializations well established outside the health university. Now, if you link it with health and if you link it with safety, which is the theme of today's conference, then what will happen if you don't wash your hands well and you get a nosocomial infection? What if you don't follow the ICU protocols and a ventilated patient gets VAP? We think it's the patient safety, but what beyond safety? Beyond safety, expenditure. In a clear way, expenditures, healthcare expenditures are increasing, the costs are increasing, the opportunities are there, and the choices are many. So in today's all this gamut, our students, our faculty should understand that every action we do on our patients, every test that we do or we do not do has cost associated with it. Doing a test has a cost, not doing a test has a cost. Sitting here today and not sitting there today has an opportunity cost. So these are the costs which we should understand, because our students of tomorrow, sometime or the other, have to understand how to invest their time, where to invest their time. Now today we have the Ayushman Bharat, we have government as well as public insurances coming in a big way, because the healthcare costs will increase so much. Gone are the days when we were medical students. There was one King George Medical College, KGMC here. Everyone came here. How much did it cost? Nobody bothered. If the patient died, you felt bad. But now there are intangible costs of death. There are wages lost when a person dies. When there's no nurse and you are sitting and nursing your patient, then what is the cost associated with it? These big issues have to be understood when a student participates as a player, as a team member in a hospital, or as an administrator in a hospital, or sets up his or her own practice. This is something we totally forget. Now, there are so many challenges here. We have the pharmaceuticals. So where will the pharmaceuticals take away the rational, ethical thinking of a doctor? We have to think about it. ATCOM touches it briefly, but it is beyond ATCOM. Besides pharmaceuticals, you have the social media, the televisions, campaigns which are wrong, disinformation campaigns which are going on, wrong information, disinformation, cyber fraud. We have to be ready. And Dr. Madhuri said they're going to launch the digital accreditation. Now with digitalization, has somebody worked up the cost of digitalization? How will it impact healthcare costs? Because it's not simply digitalization. There are many inbuilt costs into that which haven't been really worked up to the best of my knowledge. We talked about telemedicine. We don't know its costs associated either to the patient or to the provider. But if we talk from the societal perspective, what are the costs to us as a society? So I'm leaving these big questions open. This is not a new topic, but a topic we don't touch.
Not addressed, Radhika.
No, we are uncomfortable touching costs because we think we are goody-goody doctors, gods, godliness, that's all.
I think our culture doesn't permit discussion of money very openly. And perhaps that is another negative part of discussing economics. We're not upfront about loss and profit. But I think the lowest costs of healthcare if you look across the globe. And that is the reason why we are entertaining medical tourism. Much as we may complain, we do have certain advantages that if we hold on to, we could possibly provide better and more cost-effective healthcare to our people. The point is, as medical professionals, we were never taught economics of healthcare, and we all learned it through hit and run, mistakes. What about the new generation? Do we leave them to suffer exactly the way we did? Or do we incorporate it somewhere in their educational training? Do we put it in their curriculum? If so, where? If not, then what?
Thank you. This is a very important question. I've been thinking about it. I tried to introduce it to my postgraduates. I got a PG in pediatrics to do thesis on it. So it was the cost effectiveness of different alternatives for treating community-acquired pneumonia and made him go through all the costings, etc. But that was N of 1. And we're talking of the larger universe with so many students, so many teachers. I would think, first of all, another way where some interested teachers can take it up as a specialization. Not everyone, I wouldn't say like a teacher's training, everyone should know it. A group of core faculty within each institution. And I like Dr. Abbas's idea of resource sharing. So what if there's a resource sharing and a consortia of people interested in health finance, health economics, and they can spread the message and train the people in academy, which Dr. Madhuri would be making. Then we could talk about things like, definitely now, the electives. That is a very important source. And I was going through the electives offered by different universities, including KGMU, where we made 30 plus before I left. We could not make a health economic elective because faculty were not comfortable doing it. And I couldn't take it on my own because there has to be a continuity. The other thing which I found is useful is there are good publications on cost effectiveness, cost benefit, cost minimization, cost utility analysis. And when we do a journal club and critical appraisal, we should purposefully keep a couple of articles on costing and technology assessment and healthcare finances, because that will open the students' eyes that there is a big domain. And what I practiced was what I called it an extended journal club. So in the journal club, we discussed the paper. In the extended, we read more about it. And we sort of tried to internalize it and come up. So those are the simplest ways we can do it for the UGs and PGs. And what I practiced was, after my training or my awareness, when we had a clinical case presentation, then I asked the undergraduates, how much do you think this patient would have spent reaching here today? The journey of the patient, how much did it cost? The stay here, how much is it costing? And what when the patient goes home? How much more will they have to spend? These are simple ways we can build in. It doesn't need high-tech economist brain. It's a common sense.
And then we should include the polypharmacy somewhere in the middle
The
of all that.
polypharmacy,
Which is not just cost, but it's also adverse reactions, it's also patient
Exactly.
safety. It's so many things put together. Absolutely, madam. Dr. Kankar, would you like to add something to it? Dr. Raghavan, sir, please, sir.
Yeah, I think on the last subject, very well brought out and very well explained. My take is slightly different. Now the NMC is now requesting, made a lot of changes in terms. why can't they insist for every medical college to have a department of computer science, a department of finance? Need not be the greatest, where, there can be some education to doctors are the poorest in terms of cost-effective management. Either they will say out of this thing, everything can be done free and things like that, or they would go ahead to a corporate type style of, if you actually calculate the cost of a particular treatment for a particular disease, I think there are methods to do that. And if you do that, I think we will be able to come to some sort of a conclusion in terms of what can be ideal.
I think
So that
Dr.
type of an
Parekh-
exercise,
yeah, I
and
think
there
Madam
are
is planning to-
excellent cost accountants available in the corporate sector in India right now, only for health.
Yes.
I'm not talking, they should not
So,
confuse with general this thing.
Yeah, I'll just add to that the initiative has already started. The Health Technology Assessment Department is the nodal center for the Ministry of Health. It's being taken at the national level. PGI Chandigarh is hosting it, and they are at the moment running a thing on cost effectiveness and how to optimize costing for cancer treatment of the commonest. And the last meeting, because I'm a member of that, the last meeting it was discussed that because this cannot happen at the undergraduate, it is at the clinical level. So there's standard treatment guidelines, and as per that, what actually happened, the biggest roadblock is the poor quality of data. And that is why if I put the initiative, the first initiative we are going is setting up a department of digital health to get everyone savvy into understanding health economics through data science. So that is going to be the real game changer.
I may be wrong, but I think the introduction of Ayushman Bharat or Ashtra, the Mahatma Jyotiba Phule Yojana, all these government schemes where, and even the health insurance, where the reimbursement is based on the rationality of the expense, is forcing a lot of practitioners to be great. Yes, sir?
Yes.
I think Dr. Singh, please, sir.
I think after the first round of discussion, I think one thing which we have yet not discussed is that the integration, the new education policy is concentrating as far as the medical education policy is integrating of modern medicine with the Ayush. When we are talking about the patient safety, so have we, whether we are in a very comprehensive manner, have we discussed it? Have we thought of? Have we analyzed how the treatment, when we are talking about the economics, whether we are ready with the answer, with this integration is required, not required, up to which limit it is required. So this is one thing I feel is something
Very true, sir.
And number two, ma'am, I will take 2 minutes.
Please, sir.
Number two, everybody was talking about e-learning, computer-based learning and everything, simulation labs and all. There are many medical colleges in India, it's a fact, that who are not having sufficient number of medical teachers. There should be a discussion whether the absence of medical teacher versus presence of these digital methods of learning, both are equal, or whatever competency we have talked about the competency, whether that competency which the students are getting from anatomical dissection table versus open cadaver dissection, whether both are same or not, we have not discussed. We are just copying from West and we are putting it in Indian scenario where the teachers are not, the supervisors are not there. Because they have supervisor where we don't have supervisor. So this is number two. And number three, when we talk about the patient safety, we should also discuss about the competence and education of the nursing and the technician along with our UG and PGs. Unless until we are not integrating the nursing and paramedical education, the patient safety would be compromised. This is my say.
I think, sir, interprofessional education has come to stay. It's a question of when we actually adopt and adapt to it. It's a question of this decade or the next, but interprofessional education is going to be required. Otherwise, we simply cannot use the term healthcare team. So I think your
And,
point is very well taken,
I think
sir.
one thing more that when we talk about the competency, there is no objective parameter to assess the competency. When we talk about the competency, we have given the competency-based education. But whether we have the objective parameter to assess whatever competency we have given is really on the ground competency is there or not.
So I think the difference between lifelong learning and lifelong practice and actually just being
And if he's competent, he goes to the next stage. So time is a big factor which you brought out actually. Time is a big factor for us because of 4.5 years. But in competency-based education, actually you can learn at your own pace. That is what is missing in the present.
I just made one quick comment because I thought there was a very important point that our chairperson brought out on this integrated approach. Like it's coming in of a modern medicine and Ayush integration, and I think that's one thing the health universities will have to take a lead, because it's only we who have both factors and scientific evidence for that, for or against. It's a responsibility for us, and one of the initiatives is we have started this for both clinical as well as research, where giving and creating a SOP of how it can be done, because the standardization is very important, and we've created the SOP.
Okay, thank you, ma'am, for that. Okay, the clock says I still have time for a quick question, but also with a quick answer. Yes? Perfect. There is one stakeholder, rapid fire, absolutely, sir. There is one stakeholder we haven't discussed so far in any university initiative. What is the role of the consumer? What is the role of the patient himself in, if we call it the hospital quality assurance? How does the patient play a role in his own safety? Okay, ma'am.
Quick answer to that, we have not pulled in the patient adequately. We have not empowered the patient, we have not given them voice. Now we have to involve the patient in planning patient treatment, getting feedback and assessing our providers based on patient feedback in times to come.
So I second that, because the patient has now become a consumer. If you're under that, even Ola you give a feedback. Where is the feedback from the patient?
Point taken.
Yeah.
Yes, sir.
Regular feedback from patients has become a normalcy for the NABH accreditation, and also NABH accreditation has a full chapter on patient and family education. So these two aspects, there are different questions we are looking at.
Okay. Sorry, sir. Bolliye.
So, I mean, the patients are very well informed. Actually, they have already researched, before, they have Googled, they know what exactly they want to expect. And we as a doctors, we need to train the students, and we as a clinicians need to be aware, and we just can't take the patient for granted. So many a times, unfortunately, that's the situation, and empowered patients, I think we as a teachers, clinicians have to be role models, and unless of course we do that, then we'll not be able to maybe pass it on to the students, and obviously we are seeing these cases of litigations and manhandling and all these things. So I think to minimize this, we really need to see that there is a proper planning. Yes.
But sir, we are talking of patients in terms of hospital practice. What about looking at the same patients as participating in the healthcare education? We are very backward in that. I don't think we have adopted the standardized patient system or anything similar. So any observations on that?
I think NMC has started the incorporation. I mean, you have to adopt the families now. So when you are adopting the families and you are going there, you are understanding the patient from their perspective. So I think slowly it is taking place. But as far as we are talking about the feedback, so I'm sorry, but feedback can be of two types. One is really given by the patient, and number two is created by us in favor of. So there has to be analysis on that point also.
Investment in education.
Come forward in this. So government institutions can easily approach the corporate also, corporate groups. They can help and support in that. So lot many things are there. If you have a will, then there is a way for that.
Dr. Sauji, this is a question which is related to the technology you were speaking about. It says healthcare professionals need to embrace new technology. What can be done to facilitate this for us?
No, actually, I mean, it starts with oneself. I mean, how, as a culture in your institution, in your organization, how you are working it. So, technology, I mean, how you are using it and where you are using it. So, first, whether it is for teaching training, whether it is for patient care, or whether it is for any other reason. So, I think we really